I want to thank the organizers for inviting me. I want to acknowledge Dr. Terry Ruddy, who I think is a rock star in our field. And I don't say that lightly because I realize I'm in Canada and Gordon Lightfoot came from Canada. But both Terry and I were privileged to train with real leaders in the field, Barry Zaret and Bill Strauss. And they gave us the liftoff in the 70s. And Dr. Ruddy is someone who I regard as really taking us into outer space and really pushing this field forward with his close attention to quality control, his understanding of basic physiology, and his making PET bulletproof and reliable and introducing the world to myocardial blood flow in a clinical way that's highly reliable. So thank you, Terry, for all your contributions. And of course, he and I share a big interest in blood flow with SPECT, and we'll be talking about that. So without further ado, I'm going to talk about some applications. We have many different cameras now that are available. At Rochester, 11 years ago, we started with a Spectrum Dynamics D-SPECT that has 9 detectors that oscillate like detectors. And like that black hole prem that you showed with radio telescopes, actually doing something very similar to what this camera does, but on the space of the Earth was when that black hole was actually produced. Spectrum Dynamics also has a Veriton, which has 96 detectors with 12 columns of multiple detectors each. The DigiRed systems are cesium iodide solid state, and the GE cameras are pinhole collimated as opposed to general all-purpose collimated cameras with 19 detectors or more. So these are the solid state cameras we have. My discussion today will principally be with the D-SPECT. That's what we've been using predominantly. So Dr. Soman has talked to us about technical advances. Certainly, one of the things CZT and CSI can do compared to sodium iodide is it gives us miniaturized detectors, which are as sensitive as these large detectors on the previous sodium iodide cameras. They're high efficiency, they have high spatial resolution, they have high energy resolution, and they're faster at imaging and produce less motion artifact because the patient doesn't have to stay as long. There's a wide clinical operations envelope. Patient comfort and satisfaction are enhanced. Morbidly obese patients, an underserved population in cardiology and cardiac imaging, is well served, as Dr. Soman has shown us, with CZT SPECT. Now, for attenuation correction, we use a 2-position imaging to help optimize our understanding of what's true and what's artifact. CT attenuation correction is used in a minority of SPECT labs across the country. But with this emission attenuation correction software, which Dr. Soman has introduced us to, this TrueCore, which was developed by Spectrum Dynamics, other systems are developed as well. We actually have a handle on an AI approach to, which is trained upon CT attenuation correction. And we also use Prone Plus imaging, which has been validated with relative to obstructive physiology, obstructive anatomy. So there's the potential for higher efficiency and expansion of imaging roles. This is an example of someone who received a single dose of stress-only 2.9 millicuries with perfectly diagnostic imaging back in 2012. The exposure was less than 1 millisievert, so really major advances. Here's a 1 to 2 minute gated acquisition with quantitation. And for a stress first only, we get ultra low dose exposure of just 1.25 millisieverts in such a study. So today I'm going to be very selective. I've got a lot of slides I'm going to run through quickly to show you, going through the weeds, how we've sorted this out over time. Let's start with some TrueCore or AI approaches to emission attenuation correction. Stress first, if it's a normal study, we don't need to do resting imaging, but this was based on a 17,000 patient SPECT CT series that came out of Houston's lab over a decade ago. So we do need some sort of formal attenuation correction. This is the prone plus approach. You can see the deep learning curves for in figure A patients and figure B based on coronaries. There is a slight improvement based on this deep learning approach to obstructive coronary disease, which can be obtained through a prone plus approach. The emission approach, Dr. Soman has already talked about. In the interest of time, I'll just mention that we use the same acquisition workflow with the DSPECT. You run this automated correction program. You can see that in this phantom, the attenuated initial image without attenuation correction is corrected nicely on the CT attenuation correction image, and the emission is trained upon the CT. So we actually presented a study on this, which Dr. Soman showed us briefly last year at the nuclear medicine meeting. Now, a few weeks ago actually in Toronto, our group showed this case of a patient who was morbidly obese, 395 pounds, BMI of 55. And you can see in the supine and upright imaging, there's an inferior attenuation defect. And in the upright, we see an anterior as well as inferior. And the EMAC image nicely corrects this. Here we see a 60-year-old female, a pre-liver transplant patient who was referred for imaging, and we see that the stress supine, stress upright are showing some attenuation artifacts, which are nicely resolved with the emission attenuation correction. Here's a typical case of a 77-year-old man, history of GERD, had chest pain. You can see the supine and the upright attenuation issues, which are completely resolved with the emission attenuation correction. Takes about, you push a button, you have a little supercomputer there, it takes about 2 minutes and 15 seconds per image, and it corrects it very nicely. Here's another patient with a variety of defects, atypical chest pain, had a history of normal coronaries over 12 years ago. And you can see the perfusion is clearly normalized when we go to the emission attenuation correction images. Very nice result. Now, are we just whitewashing these images? Is this really working? Here's a patient who I personally had seen in the emergency room who had a non-exertional jaw discomfort, denied any exertional symptoms, actually syncoped while gardening, and had a normal looking EKG, really a very unimpressive minimal troponin leak. So I decided to do an exercise first test, which probably in retrospect was a mistake because it was a floridly positive exercise test with hypotension, angina, major ST changes, and this was his stress image. So when we applied this to you can see the dysfunction here. The quality of these images is graded by the software that I use. The images are actually quite sharp when you look at them on the screen. RV function looks intact. And here's the emission attenuation correction. It preserves all of that stress perfusion defect. It was extensive. Indeed, the patient went on to have a coronary angiography and went on to revascularization for multivessel coronary disease. Now here's a somewhat more subtle case where you're seeing a combination of a larger stress perfusion defect than rest perfusion defect. The EF was reduced. And on EMAC, it preserves the relationship of some scar with additional superimposed ischemia. So we're not just whitewashing these defects. It is able to, the program seems to perform quite well in our experience. We've done this for almost a year now that we've been using the emission attenuation correction algorithm. Quite good at preserving the true perfusion characteristics of patients. Now there is a major bugaboo. Dr. Soman taught us a lot about attenuation, but when you have a lot of splanchnic scatter, you can actually intensify the ramp artifacts. And with this particular, no matter what attenuation method you use, if you have a lot of splanchnic Compton scatter, you're not going to be able to correct it. In fact, you may worsen it to the extent that you have any superimposed attenuation artifact as well. So here's an example which looks terrible and was not corrected with EMAC, was made worse. And it completely resolved by just re-imaging the patient after 45 minutes. So remember, you really want to get your patients at least walking to get some splanchnic vasoconstriction to reduce that Compton scatter. It's well known that the splanchnic scatter will cause some overcorrection of the inferior wall, even with SPECT CT. So the EMAC is based on a deep learning algorithm using CT attenuation correction as the reference standard. It takes just a couple of minutes per image to do. Provides excellent incremental value in our experience to two-position imaging, and using the Prone Plus AI algorithm. We do recommend caution with regard to handling the splanchnic scatter issue. Now, Anas Shawad, who is with our fellowship and is currently training in heart failure down in Texas and plans to come back to join us on the faculty, found a unique application we reported last year at Assoc in the use of resting perfusion imaging with SPECT, using the D-SPECT, to identify scar in patients who are on mechanical circulatory support. This is such a patient. The patient was not able to undergo the usual cardiac MRI to define the scar and identify potential sites for VT ablation preoperatively. And indeed, we identified areas of focal scar, as you can see in this these scans. And indeed, this was quite accurate in identifying the specific locations where the VT was originating. And so our group has done a number of these over the past year since Anas first started this. And it is helpful for those patients who really cannot, because of an impella or some mechanical circulatory support, cannot get a cardiac MRI for fibrosis. So we've had very good experience with that. Let's move on to an area close to Dr. Ruddy's heart and mine, which is the use of CZT SPECT for blood flow. We've done over 600 cases in the past 2.5 years on the D-SPECT, and our clinicians are ordering it because they find it useful. MBF and MBFR can be measured with CZT SPECT. Clearly, PET is the gold standard. And day-to-day reproducibility is good, inter-observer variability is good. These are all conclusions that Dr. Ruddy and I came to in our All About Flow Symposium from last year at Assoc in Orlando. It's useful in diagnosis and prognosis of obstructive and non-obstructive ischemic disease. We are using it routinely, although we need better validation. We are using it in an observational way for our cardiac transplantation patients at Rochester as well. So we think it's ready for careful clinical implementation. And we think that there are patients who can be defined who benefit from it. And we have a big interest. We'll be talking about in Ottawa this trip to review some of our data from Rochester and see how we can develop a multi-center registry to look at its larger term applications. So here's some quick cases. Here's a 73-year-old man who presented for a preoperative evaluation for nephrolithiasis, who had a new left bundle branch block, atypical chest discomfort, was short of breath, some other risk factors, and a preoperative SPECT was ordered. We did a blood flow study, and indeed you see a combination of ischemia and scar in the inferior wall. We did a gating, and you can see the patient's ESVI was 53, so it's dilated. We used 10 to 35 as normal for ESVI, cc's per meter squared. EF was reduced at 44%. And these are the flows, they're terrible. You can see that there's global and regional severe stress flow reduction, relatively preserved rest flow, with severe global and regional flow reserve abnormality. So this is consistent with multi-vessel disease. And looking at the PET data, these are not SPECT data, these are the PET data from the Brigham's paper in 2017. Basically, we're looking at a coronary flow map of the population they studied, over 4,000 patients. And you can see that this patient, using SPECT data, would fall into this left lower quadrant of low stress flow, low flow reserve, which would identify significant survival benefit of revascularization. And with that in mind, the patient underwent angiography, had severe multi-vessel disease, and had successful bypass surgery days later. 2 years later, this year, he remained stable with ischemic disease, asymptomatic on GDMT. In addition, here's a very interesting case picked by the fellows for our ASNC meeting. This was one of their favorite cases, MBF cases of the year. This is a patient who's 70 years old who had a history of extensive multivessel CAD, 8 prior stents, diabetes, COPD, chronic kidney disease, referred for the nuclear lab for evaluation. What we're seeing on the MPI is a combination of ischemia and infarct in the distal LAD and what looks like distal posterolateral or circumflex distribution. When we looked at the flows, however, it's quite interesting that if you look at the RCA, there's actually no augmentation at all in the RCA, whereas we had a blunted flow reserve of 1.7 in the LAD and circ territories. So left heart cath was done and confirmed the presence of a culprit stenosis and focal dissection in the proximal right coronary. The patient was stented successfully, reported symptomatic resolution 2 weeks later, and more than a year later after this 9th stent, he remains symptom-free on GDMT. So I think the major teaching points are that there are multiple studies now which demonstrate quantitative dynamic MBF and MBFER with PET provide incremental diagnostic and prognostic evaluation for CAD, and now so does a growing literature with CZT SPECT, including patients with non-obstructive coronary disease. This case shows the utility of CZT SPECT flow and flow reserve to identify the culprit residual ischemic territory in the RCA, which influenced the decision to stent the RCA. Specifically in this case, RCA stenting provided symptomatic relief long-term, and we believe that this is typical of the capacity of SPECT flow to identify culprit ischemic territories. Here's a case of a 55-year-old woman who had a history of a Minoka in 2014, MI with normal coronaries at our institution. She came in and had normal looking perfusion, normal function, normal flows. Her regional and global flows are normal. Her flow reserves are normal. We treated her for her GERD and she's not had any residual symptoms 2 years later. Final case for this morning of the flows is an example of a routine procedure. Our heart failure team regards the MBFs that SPECT is providing as highly reliable for identifying freedom from significant CAV, and we've been routinely doing these. We obviously need more data on this, and we're collecting it in a REDCap database currently. In this case, the stress flows and flow reserves were all normal, and we find it useful. There's a couple of different algorithms that have been defined by PET, which we refer to for our SPECT interpretations as well. We have essentially a flow and flow reserve based definition of CAV01 versus CAV23 for low and high risk. This is the one by Paco Bravo and Marcelo De Carli from 2018, showing a combination of the MPI pattern with stress flow being less or more than 1.7, and either a normal or an abnormal perfusion pattern with EF as well to help us identify these. Here's the paper from Einstein from last year in JACC. This is that central illustration, which works well. Look at this hazard ratio. For 5-year, the middle bar, 5-year CV death or retransplant, there's a hazard ratio of 12. This is using PET for the use of MBFR with a cut point of 2.0 for identifying transplant death, retransplant or CV death. Very impressive. And so our experience has been that flow seems to work with SPECT. It is more time consuming than PET. PET is clearly the gold standard. We're planning to install a PET CT in our heart center within the next year after many years of agitating for it. But SPECT can get it done. It's more labor intensive. It takes longer. The radiation doses are higher than PET. But if your center doesn't have it, you can get very acceptable results in our experience over the past 2.5 years at Rochester. Let's move on to metabolic imaging. Let's see who's been reading the literature recently. Does anybody recognize this image? Does anybody know what you're looking at here? So what if I told you in the top row is actually thallium? I know Dr. Soman didn't raise his hands, but I know he knows this case very well. And in the second rows and alternate rows, we see tech pyrophosphate. This is a patient who has cardiac ATTR amyloidosis. And you can see that the myocardial region has been exquisitely defined by the perfusion with thallium. And because of the superior, excellent energy resolution that CZT provides, we were able to actually simultaneously image on the D-SPECT both thallium and pyrophosphate imaging. And of course, we presented this case last year at Assoc and just published it over the summer. We also get from the D-SPECT sort of the classic planar reproduction image in the bottom center, and the positioning ellipse, which is basically PET, SPECT, and you can see both RV and LV. I don't have a pointer in the image on the right. This is a case with LV thickening, preserved apical function on echocardiography consistent with amyloid. Now here's a patient with this so-called dual isotope, simultaneous dual isotope acquisition, which we do at 60 to 90 minutes. Where it's negative, you can see that the region of interest of the myocardium, defined by the thallium, actually does not have activity in it, and the activity is clearly in the LV cavity itself. And so evaluation of cardiac ATTR amyloidosis by dual isotope perfusion metabolism SPECT is possible with high sensitivity. The problem, of course, is that we don't have any thallium currently, which is a bit of an issue. But this technique was defined by the Cedars group. This is from their 2020 paper in the JNC, showing that the value of this simultaneous dual isotope acquisition, this was not with CZT, this was with regular sodium anger cameras in 2020 when they reported it. You can see that the effect was to reduce the equivocal patients in both the AL and the normal groups. And we've had similar experience now with CZT SPECT. So in this meeting a few weeks ago in Toronto, our group presented this patient who, in the upper value, I realize it's hard to see, but we clearly identified using a technique we call asynchronous dual radiopharmaceutical approach, where we inject HMDP. We prefer HMDP to PYP because it has a bit more rapid blood pool clearance. And we're able to image at 60 minutes and see the presence of the HMDP. But to understand precisely where it's located, we find it very helpful without moving the patient. We tell the patient, be very still. We inject 10 millicuries of cestamide and image in 5 minutes for 5 minutes. So in less than 90 minutes, we're done. And we clearly can identify nice cases of positivity and negativity, clearly defined. In the interest of brevity, I'm going to just show you a case of someone who presented for consideration using this new approach. This is the HMDP planar and SPECT positioning ellipse. This is the HMDP in a different color scale. And this is the MIBI also, showing the exact same area. And of course, when we use the dual approach, we can use the regions of interest to precisely define where the metabolic activity is. And of course, we can see the ribs well enough to know that this is 3+. This is clearly higher than the rib activity. So we get two standards for evaluating the amyloid, the HMDP distribution. Here's another case of someone who was done at an outside hospital. This was reported as positive, and they were planning to start this patient on tafamidis. One of our heart failure attendings was concerned about this, was asked for verification. So we looked at the 1 and 3 hours. We were not convinced at all that this was myocardial activity from this outside scan. And of course, with HMDP, it's actually recommended not to do heart to contralateral lung ratios. So we look at those images, but we don't quantify them or report those. And in this particular case, clearly the activity of the HMDP was within the lumen of the LV, not in the myocardium. So we knew that this was a patient who did not have, in fact, any amyloidosis and a change therapy for this patient. So we think this is a very good approach. We're using less than 10 millicuries of HMDP, less than 10 millicuries of cestamide. So we're getting less than 5 millisieverts, which is ultra low dose exposure in these patients for amyloid evaluation on the D-SPECT with this approach. Metabolic imaging can also be done with MIBG, but I don't really have time to go into that today. In 2018, at the 25th anniversary celebration of Assoc in San Francisco, our group presented this study, which we subsequently published, which is to look with our pulmonary hypertension specialists at CT SPECT imaging of blood pool in 10 minutes. We do these images in 10 minutes. And you can see serially in patients with pulmonary artery hypertension who have greater new or more intensive therapy for their pulmonary hypertension, improvements in both RV and LV function in a period of 6 months. And this improvement in function documented using routine blood pool SPECT imaging enabled us to correlate that with an improvement in heart rate expenditure with stepping. So thank you for your attention, and thanks again to the organizers for the possibility of presenting with you today. Thank you.